Welcome to the Deep Dive, where we cut through the noise to get you the essential knowledge you need. Today, we're tackling a crucial, often sensitive area in healthcare: male reproductive problems. For you, a nursing student, mastering this content from Lewis's Medical Surgical Nursing, 12th edition, is key to providing truly holistic patient care.
Exactly. Our mission today is to distill the core pathophysiology, assessment, and management of these conditions into clear, actionable insights. We'll demystify complex terms, highlight the nursing process, and connect your learning directly to real-world patient scenarios, ensuring you're ready for both your exams and your future patients.
Okay, let's unpack this by focusing on the prostate gland, a small but mighty player. We're starting with benign prostatic hyperplasia, or BPH. What exactly is it, and how incredibly common is it?
Right, so BPH is essentially an enlarged prostate gland. The issue isn't just the enlargement itself, but really how it obstructs the flow of urine from the bladder through the urethra. Think of it kind of like a gate in a pipe that gradually narrows, making it harder for urine to get through.
A narrowing gate, okay. And how common are we talking?
Oh, it's incredibly common. Statistically, by age 50, about half of men will show some signs. And that number jumps to over 70% for men aged 60 to 69. It's almost, a given for many men as they get older.
70%, wow. That's astonishingly common. So what's actually causing this widespread overgrowth, and what makes some men more susceptible than others?
Well, the primary drivers are hormonal changes associated with aging. There's a hormone, dihydroxytestosterone, or DHT, that stimulates prostate cell growth. As men age, they tend to produce and accumulate higher levels of this DHT, which leads to the enlargement. Plus, there's a shift in the balance, an increased proportion of estrogen compared to testosterone, and that also seems to promote prostate cell growth.
So hormones are key.
Definitely. And a really crucial point for you as nurses, BPH usually develops in the inner part of the prostate, the transition zone. So it gradually compresses the urethra from the inside out. This means the location of the enlargement is often more significant than the overall size of the prostate when it comes to how bad the symptoms are.
Ah, location matters more than size. Got it. What about other risk factors besides just aging?
Yeah, beyond aging, other factors include obesity, especially increased waist circumference, that central adiposity. Also, lack of physical activity, a diet high in red meat and animal fat, regular alcohol use, erectile dysfunction, smoking, diabetes, and definitely a family history of BPH in a first-degree relative.
So it's not just about how big it gets, but where it grows. And our lifestyle choices definitely play a role. When a patient comes in, what symptoms are they typically experiencing, and how might they describe them to us?
Where the symptoms tend to creep up gradually. We group them into what we call lower urinary tract symptoms, or LUTS. You'll hear about irritative symptoms first. These are often related to inflammation or infection. Things like nocturia, waking up multiple times at night to urinate. That's often the very first thing men notice and complain about.
Nocturia, okay. What else?
Patients also report urinary frequency, urgency, sometimes dysuria or pain during urination, bladder pain, and occasionally incontinence. Then there are the obstructive symptoms. These are caused by the actual physical squeezing of the urethra. So that means a decrease in the force and caliber of the urinary stream.
Like the stream is weaker.
Exactly. Difficulty starting a stream, what we call hesitancy. Intermittency, where the flow stops and starts several times during voiding, and then often jubbling at the very end.
I can absolutely imagine how disruptive those symptoms would be to daily life.
Yeah.
As nurses, how do we assess the severity and impact of these voiding issues?
Yeah, it really impacts quality of life. A great tool for assessment is the American Urological Association's Symptom Index, the AUASI. It's basically a questionnaire. We ask patients about things like the sensation of incomplete bladder emptying, how often they go, intermittency, urgency, weak stream, if they have to push or strain, and nocturia. The scores help us classify symptoms. 0 to 7 is mild, 8 to 19 moderate, and 20 to 35 severe. This guides treatment decisions, but remember, it's an assessment tool, not diagnostic for BPH itself.
Okay, that makes sense. It quantifies the bother factor.
Yeah.
Now, this brings up a critical question. What happens if BPH isn't managed effectively? What are the potential dangers or complications we need to be vigilant for?
That's a really important point. If left untreated or if treatment is delayed, BPH can lead to some pretty serious complications. The most immediate one is acute urinary retention. This is a sudden, painful inability to urinate. It's often an emergency and requires immediate catheter insertion.
Wow, okay. That sounds awful.
It is. Also, because the bladder isn't emptying completely, that stagnant urine becomes a breeding ground for bacteria. So frequent urinary tract infections, or UTIs, are common. And these UTIs can sometimes travel up to the kidneys, causing pyelonephritis or even lead to sepsis in severe cases.
Sepsis from a UTI.
It can happen, yes. Other potential issues include bladder calculi stones forming in the bladder, often because the residual urine becomes alkaline. And in the long term, the constant back pressure on the kidneys from urine that can't get out can cause hydronephrosis, which is extension of the kidneys, and eventually lead to renal failure.
Renal failure. So this can have really severe consequences down the line. It sounds like early detection and intervention are absolutely key. How do we as healthcare professionals get a definitive picture of what's happening inside? What diagnostic studies are typically performed?
Exactly. Early management is crucial. The diagnostic process starts, as always, with a detailed history and a physical assessment. A digital rectal examination, the DRE, is fundamental. We're feeling the prostate through the rectal wall to estimate its size, symmetry, and consistency. In BTH, it typically feels symmetrically enlarged, firm, and smooth.
Okay, the DRE. What else?
A urinalysis, UA, and urine culture with sensitivities are done to look for bacteria, white blood cells, or blood, which might indicate infection or inflammation. We also check a prostate-specific antigen, or PSA, blood level. Now, BPH itself can cause a slightly increased PSA, but its main role here is to help screen for prostate cancer, so it's an important part of the workup.
Right, ruling out cancer is key.
Absolutely. We also look at serum creatinine levels to assess kidney function. If the creatinine is high, suggesting potential kidney issues, a renal ultrasound might be ordered to check for hydronephrosis. To directly measure how well the patient is voiding, we can do uroflowmetry. This measures the volume of urine expelled per second and the flow rate, helping quantify the blockage. And a post-void residual urine volume test tells us how much urine is left in the bladder right after the patient tries to empty it. It assesses the degree of obstruction.
Okay. Are there more invasive tests?
Yes, if the diagnosis is still unclear, or if we need to really visualize the inside of the urethra and bladder, a cystoscopy might be performed. Sometimes urodynamic or pressure flow studies are done to get detailed information about bladder function and outlet resistance.
Got it. So once we have a diagnosis, what are the goals of care and what's the spectrum of management strategies available, from simple lifestyle changes all the way to more advanced procedures?
The main goals are pretty straightforward. Restore bladder drainage, relieve those bothersome LETS, and prevent or treat any complications. And importantly, treatment is really based on how much the symptoms bother the patient and whether there are complications, not necessarily just the size of the prostate gland.
So patient experience drives treatment.
Precisely. For mild symptoms, say AUA scores from 0 to 7, we often start with the most conservative approach. Active surveillance, or what some call watchful waiting. This usually involves annual PSA tests and DREs. Lifestyle changes are foundational for almost everyone. This involves educating patients to decrease bladder irritants, things like caffeine, alcohol, carbonated drinks, artificial sweeteners, spicy or acidic foods. They should also avoid certain drugs, especially decongestants, and some anticholinergics, which can worsen symptoms. Restricting fluid intake in the evening can help with nocturia, and using a timed voiding schedule, sometimes called bladder retraining, can also be beneficial.
That's great practical advice. What about medication options? What's the nurse's role in educating patients about these?
Drug therapy is a major component. There are two main classes we use. First, there are the 5-alpha reductase inhibitors. Examples are finasteride, brand name Proscar, and dutasteride, Avodart. These drugs actually work by reducing the size of the prostate gland. They block the enzyme that converts testosterone to DHT, that growth-stimulating hormone we mentioned.
So they shrink the prostate.
Yes, exactly. They're generally more effective for men who have larger prostates. The downside is they can take up to 6 months to show their full effect, and a possible side effect is decreased libido. And a really critical point for nursing a drug alert: women who are or might become pregnant should absolutely not handle finasteride tablets, even broken ones, because of the potential risk to a male fetus.
That's a crucial safety point. What's the other main class of drugs?
The second class is alpha-adrenergic receptor blockers. Common ones include alfuzosin, uroxetrol, doxazosin, Cardura, and tamsulosin, Flomax. These drugs work differently. They don't shrink the prostate, but they relax the smooth muscle of the prostate gland right around the urethra and also the bladder neck. This relaxation helps open up the channel, facilitating urine flow.
So they help with flow, not size.
Correct. And the good thing is, symptom improvement is often seen much faster, sometimes within days to weeks. A common side effect patients should know about is retrograde ejaculation, where semen travels back into the bladder during orgasm instead of out the penis. It's not harmful, but definitely something to mention.
Retrograde ejaculation, okay. Any other drugs?
Sometimes these two classes are used together in combination therapy, like dutasteride plus tamsulosin in a single pill called Gleason, which can be more effective for some men. Also, erectogenic drugs like tadalafil, Cialis, which are typically used for ED, have been found to help reduce BPH symptoms too, so they can be an option, especially if the man has both conditions. And just briefly, you might hear patients ask about herbal therapies like saw palmetto. It's important to know that studies have consistently shown it offers no real benefit over a placebo for BPH symptoms.
Good to know about saw palmetto.
Mhm.
So we've covered conservative approaches and drug therapies. What about minimally invasive procedures? For nursing students, what are the key takeaways for these options?
Right. Minimally invasive therapies, or MITs, have become much more common. The big advantages are usually decreased hospital stays and fewer adverse events compared to traditional surgery. There are several types, but they generally work by using heat, lasers, or mechanical devices to either destroy, vaporize, or compress the obstructing prostate tissue. For instance, photoselective vaporization of the prostate, or PVP, uses a high-power green laser to basically vaporize the tissue. It offers rapid symptom improvement and can handle larger glands, but patients might have irritative voiding symptoms for a few weeks afterward.
The lasers, okay. What else?
There's transurethral microwave thermotherapy, or TUMT. This uses microwaves delivered via a transurethral probe to heat the prostate tissue, causing it to die off, essentially coagulative necrosis. It's an outpatient procedure, and ED or incontinence are rare, but patients often need a catheter for several days afterwards. Another one is the prostatic urethral lift, or PUL, marketed as Urolift. This is quite different. It uses tiny permanent implants that are placed to sort of mechanically hold the urethra open by compressing the prostate tissue from the sides.
Like tiny tiebacks.
Kind of, yeah. The appeal is minimal risk of sexual side effects like ED or retrograde ejaculation, but it's newer, so we don't have as much long-term data on durability. The key nursing takeaway for all these MITs is thorough patient preparation about what to expect post-procedure, including potential temporary urinary symptoms like frequency or urgency, maybe some blood in the urine, and reinforcing any necessary medication instructions.
And when do we move beyond minimally invasive options to actual surgical therapy? What's considered the gold standard here?
Surgical therapy is generally indicated when symptoms are causing significant distress or pain, when there's persistent residual urine, acute retention episodes, or signs of complications like hydronephrosis or bladder stones. The procedure that's long been considered the gold standard for obstructing BPH is the transurethral resection of the prostate, or TURP. In a TURP, an instrument called a resectoscope is passed through the urethra, and obstructing prostate tissue is removed piece by piece using an electrical cutting loop. There's no external incision. Patients typically see marked improvements in their symptoms after a TURP.
TURP, the gold standard. Are there significant risks nurses need to watch for?
Yes, absolutely. While generally safe, nurses need to be acutely aware of potential complications. One major one, historically, was transurethral resection syndrome, or TUR syndrome. This was due to the absorption of large amounts of the isoosmolar irrigation fluid used during the procedure, leading to dilutional hyponatremia, low sodium levels. Signs include nausea, vomiting, confusion, slow heart rate, and high blood pressure.
That sounds serious.
It is. But the good news is that the widespread shift to using isotonic saline for irrigation during TURP has dramatically reduced the risk of TU syndrome. It's much less common now, but still something to be aware of. Other common complications after TURP are bleeding and clot retention, which require careful monitoring.
Okay. Are there other surgical options besides TURP?
Yes. For very large prostates, say over 100 grams, or if there's bladder damage or other complicating factors, a simple prostatectomy might be done. This involves removing just the inner part of the prostate that's causing obstruction, not the whole gland like in cancer surgery. It can be done as an open surgery with an incision or increasingly using laparoscopic or robotic-assisted techniques.
This is where the nurse truly shines. What's our role in managing BPH, especially in the perioperative period? Let's imagine Mr. Jones, a 65-year-old, is undergoing a TURP. What's our priority?
Okay, Mr. Jones. Our nursing management is absolutely foundational for his care. Preoperatively, our priorities include ensuring any existing UTIs are treated before the procedure. We administer prophylactic antibiotics as ordered, usually right before the surgery. If he's in retention, we'd likely insert a Foley catheter to restore urinary drainage, maybe using a lubricant with lidocaine gel to help with comfort. We'd also encourage a high fluid intake, maybe 2 to 3 liters a day, unless he has other conditions that prevent that.
What about psychosocial aspects?
That's crucial. Patients like Mr. Jones are often very concerned about how the surgery might impact their sexual function. We need to provide opportunities for him and perhaps his partner to express these concerns openly. We need to explain honestly that while erection problems are usually not expected after TURP, decreased or absent ejaculate volume and retrograde ejaculation are very common. Reassure him that retrograde ejaculation isn't harmful, it just means the semen goes into the bladder instead of out.
That sensitive, open communication is so important. What about immediately after Mr. Jones's TURP? What are the key nursing actions?
Postoperatively, our absolute top priorities are managing bleeding, preventing clot retention, managing bladder spasms, preventing infection, and monitoring overall fluid balance. Mr. Jones will come back from surgery with an indwelling urethral catheter, usually a large 3-way catheter. This allows for continuous bladder irrigation, or CBI, with sterile normal saline.
CBI, right. What's our role there?
Our role is constant vigilant monitoring. We need to ensure the inflow of saline matches the outflow of urine and irrigant. Outflow should equal or slightly exceed inflow. We're assessing the color and consistency of the drainage. It will likely be light red with small clots initially, gradually clearing over 24-36 hours. If the outflow suddenly decreases or stops, we need to assess for kinks in the tubing or clots obstructing the catheter.
What if it seems blocked?
First, check for kinks. If none, you may need to manually irrigate the catheter gently with a syringe of sterile saline as per hospital protocol to dislodge the clot and reestablish patency. Always use strict aseptic technique. Maintaining a closed drainage system is key to preventing infection.
Okay, CBI monitoring is huge. What about bleeding?
Bleeding management is critical. As I said, some blood clots are expected initially, but large amounts of bright red blood indicate active arterial bleeding, which needs immediate attention. Sometimes the surgeon might apply gentle traction on the catheter to help compress bleeding vessels at the prostatic fossa, but this must be managed carefully to avoid tissue damage. We also need to monitor vital signs closely for any signs of hemorrhage or hypovolemia, and we teach the patient to avoid activities that increase abdominal pressure, like straining for a bowel movement or even prolonged sitting or walking initially, as this can trigger bleeding.
What about bladder spasms? Patients often complain about those.
Yes, bladder spasms can be quite distressing. They're caused by irritation from the resectoscope during surgery or the catheter itself. First step is always to check the catheter for patency clots can trigger spasms. We instruct the patient not to try and urinate around the catheter, as this just increases spasm intensity. We can administer prescribed antispasmodic medications like oxybutynin and teach relaxation techniques.
Okay, managing bleeding and spasms. When does the catheter usually come out?
The catheter is typically removed 2 to 4 days after surgery, once the urine is reasonably clear. After removal, we monitor the patient closely with a voiding trial to ensure they can urinate adequately on their own.
What about urinary control after the catheter is out?
It's very common for patients to experience some temporary urinary incontinence, like dribbling or stress incontinence, right after the catheter is removed. This is usually due to poor sphincter tone after having the catheter in place. This is where Kegel exercises are absolutely essential. We need to teach Mr. Jones how to identify and strengthen his pelvic floor muscles. The goal is typically 10 to 20 repetitions, holding each contraction for a few seconds, done multiple times per hour while awake.
Kegels are key. How long does it take to see improvement?
We need to reassure him that continence can continue to improve for up to 12 months after surgery. Patience and consistent practice with the Kegels are vital. In the meantime, we can discuss incontinence aids like pads if needed.
Makes sense. What about discharge teaching?
Discharge teaching is comprehensive. If he goes home with a catheter, we teach him and his caregiver how to manage it. We reinforce the importance of maintaining a high fluid intake, aiming for 2 to 3 liters daily, while still advising him to avoid bladder irritants like caffeine and alcohol. We emphasize not to restrict fluids, thinking it will help incontinence. It can actually make things worse and increase infection risk. We teach him to observe for signs of UTI or wound infection. Preventing constipation is crucial, so we emphasize a high-fiber diet and stool softeners to avoid straining, which increases bleeding risk. He'll have activity restrictions like avoiding heavy lifting, usually nothing over 10 pounds for several weeks. He'll also be advised to refrain from driving or intercourse until cleared by his surgeon. And finally, we reiterate the potential changes in sexual function, like retrograde ejaculation, and remind him about the need for ongoing follow-up, including a yearly DRE if prostatic tissue remains.
That was an incredibly thorough look at BPH and the nursing care involved. Now, let's shift gears slightly to another really significant male reproductive health concern: prostate cancer. How prevalent is this, and what makes it such a critical topic for nursing students?
Right, prostate cancer. This is a huge topic. It's actually the most common cancer among men if you exclude skin cancer. And it's the second leading cause of cancer death in men in the U.S. Only lung cancer causes more deaths. Statistically, a man has about a 1 in 8 lifetime risk of developing prostate cancer. So yes, it's incredibly prevalent and absolutely critical for nursing students to understand. It involves complex screening decisions, treatments that are highly individualized, and often profound psychosocial impacts for patients and their families.
1 in 8, that's significant. What's the underlying pathology here? How does it typically behave and spread?
It's usually a slow-growing cancer, and importantly, it's often androgen-dependent, meaning its growth is fueled by male hormones, like testosterone. Most prostate cancers develop in the outer part of the gland, what's called the peripheral zone. This is different from BPH, which tends to be more central. In terms of spread, it can grow directly into nearby tissues like the seminal vesicles or the bladder neck. It can also spread through the lymph system to regional lymph nodes in the pelvis, or it can spread through the bloodstream hematogenous spread to distant sites. The most common site for metastasis is bone, particularly the axial skeleton like the spine, pelvis, and ribs, but it can also spread to the liver and lungs.
Okay, slow growing, but with potential for widespread metastasis. Who is at highest risk for developing prostate cancer?
Age is definitely the biggest risk factor. The incidence rises markedly after age 50, and the median age at diagnosis is around 66. Ethnicity is also a very significant factor. Black men have the highest incidence rates globally. They are often diagnosed at an earlier age, tend to have more advanced disease at the time of diagnosis, and unfortunately have a higher mortality rate compared to white men. Asian American men, on the other hand, have lower rates.
That disparity for Black men is really important to highlight. What else increases risk?
Family history is another key risk factor. Having a first-degree relative, a father, brother, or son with prostate cancer increases a man's risk significantly. The risk is even higher if there are 2 or more affected first-degree relatives, or if the relative was diagnosed before age 55. Diet and obesity might play a role, although the evidence is still evolving. Some studies suggest a link between high intake of red and processed meat, high-fat dairy products, and a low intake of fruits and vegetables. Obesity is also considered a risk factor. And then there's a genetic component. While most cases, maybe 75%, are considered sporadic, about 20% are familial, likely due to a combination of genes and environment. And about 5 to 10% are truly hereditary, linked to inherited gene mutations, including BRCA1 and BRCA2, which are also linked to breast and ovarian cancer.
It sounds like it can often be a silent disease, especially in its early stages. What should we as nurses be looking for, and when do symptoms typically appear?
You're absolutely right. Early-stage prostate cancer often causes no symptoms at all. That's why screening is so important. When symptoms do eventually appear, they can actually be very similar to BPH, those lower urinary tract symptoms we talked about, like difficulty urinating, frequency, regency, weak stream.
So symptoms alone can't distinguish BPH from early cancer.
Exactly. The symptoms often overlap. However, a real red flag that might suggest more advanced, possibly metastatic disease is pain. Specifically, persistent pain in the lumbosacral area, the lower back and hips that might radiate down into legs. If this kind of pain occurs along with urinary symptoms, it's highly suspicious for metastasis. Once the cancer has spread to distant sites, particularly bone, the pain can become quite severe. Bone pain, especially in the back and legs due to potential spinal cord compression or just bone destruction, can be a major issue.
Given its prevalence and that potential for silent progression, how do we screen for and definitively diagnose this type of cancer?
Screening is actually a bit of a complex and sometimes controversial topic. It really requires shared decision-making between men and their healthcare providers. Why? Because we need to weigh the potential benefits of early detection against the potential harms, like unnecessary biopsies, anxiety, and potentially overtreating slow-growing cancers that might never have caused problems.
So it's a discussion, not just a routine test.
Precisely. The primary screening tools are the PSA blood test and the digital rectal exam, DRE. Guidelines vary slightly. The American Urological Association, AUA, generally recommends discussing the option of screening usually every 2 years for men aged 55 to 69. The American Cancer Society, ACS, suggests starting the discussion earlier for men at higher risk, age 45 for high-risk men, Black men, or those with a first-degree relative diagnosed before 65, and even age 40 for those at even higher risk, like multiple first-degree relatives diagnosed early.
And what do these tests tell us?
Well, it's crucial to understand that a high PSA level doesn't automatically mean cancer. PSA can also be elevated due to BPH, prostatitis, inflammation, recent ejaculation, or even just aging or having a larger prostate. So it's not definitive, it's an indicator that needs further evaluation. Similarly, during a DRE, the examiner is feeling for any abnormalities on the prostate surface. Concerns would be if the prostate feels hard, nodular, or asymmetric. A normal prostate feels smooth and rubbery.
Okay, so if screening raises a flag, either a high PSA or an abnormal DRE, what's the next step to actually confirm a diagnosis?
If the PSA level is consistently elevated over time, or rising, or if the DRE is abnormal, the next step is usually a prostate biopsy. This is typically done transrectally, where small needles are inserted through the rectal wall into the prostate, guided by ultrasound, to take multiple tissue samples. Newer techniques like MRI ultrasound fusion biopsies are becoming more common. They can help target suspicious areas seen on MRI more accurately, which is especially useful for men who've had negative biopsies before or are on active surveillance. A transperineal approach going through the skin between the scrotum and anus is also used sometimes and has a lower risk of infection.
And the biopsy gives the definitive answer.
Yes, the biopsy is what provides the definitive histologic diagnosis of cancer. It also provides crucial information for grading the cancer using the Gleason score. Once cancer is confirmed, other tests are needed to determine the extent or stage of the cancer. These often include a nuclear medicine whole-body bone scan to check for bone metastases, a CT scan of the abdomen and pelvis, and sometimes an MRI of the pelvis for more detailed local staging. And importantly, PSA levels will continue to be monitored after treatment starts, as a falling PSA indicates treatment effectiveness, while a rising PSA can signal recurrence.
Right. Once diagnosed, how do we approach treatment? Let's consider Mr. Davis. Say he's 58, just received his diagnosis. How's his care decided?
Okay, Mr. Davis. The first thing to understand is that the care plan for prostate cancer is highly individualized. There's often no single right treatment. It depends heavily on several factors. The stage of the cancer, how far it has spread, the grade of the cancer, how aggressive the cells look under the microscope, often using the Gleason score or the newer grade group system, his PSA level, his age and overall health, his life expectancy, and importantly, his personal preferences and values.
So lots of variables. Shared decision-making sounds critical.
Absolutely crucial. Mr. Davis and his partner need to be fully informed about all the reasonable options, including their potential benefits and side effects, so they can make a choice that aligns with their priorities. For some men with very low-grade, low-stage tumors, especially if they are older or have significant other health problems, active surveillance might be a very appropriate option. This involves closely monitoring the cancer with regular PSA tests, DREs, and possibly repeat biopsies, but delaying active treatment unless the cancer shows signs of progressing.
Active surveillance. Okay. What are the main active treatment options for localized prostate cancer, like Mr. Davis might have?
The two main curative intent treatments for localized disease are surgery and radiation therapy. The primary surgical option is a radical prostatectomy. This involves removing the entire prostate gland, the attached seminal vesicles, and often part of the bladder neck. Pelvic lymph node dissection might also be done at the same time to check for spread.
How is that surgery performed?
It can be done through a traditional open incision, either retropubic, below the belly button, or perineal, between the scrotum and anus. However, increasingly, it's performed using robotic-assisted laparoscopic techniques. The robotic approach uses smaller incisions, provides magnified 3D vision, and allows for very precise movements, which generally leads to less blood loss, less pain, shorter hospital stays, and faster recovery compared to open surgery.
What about preserving sexual function?
That's a major concern. Surgeons may perform a nerve-sparing procedure, trying to carefully preserve the tiny neurovascular bundles that run alongside the prostate and control erections. This is possible if the cancer appears contained within the prostate capsule. However, even with nerve-sparing surgery, erectile dysfunction, ED, is still a significant risk, and potency is never guaranteed.
ED and what else are major side effects?
The two most common and impactful long-term side effects after radical prostatectomy are erectile dysfunction and urinary incontinence, usually stress incontinence like leaking with coughing or sneezing. Other potential complications include bleeding, infection, and lymphocyte formation. Another surgical option, though less common, is cryotherapy or cryoablation. This uses probes inserted into the prostate to freeze the tissue, thereby destroying the cancer cells. It can be an option for localized disease, but also carries risks, including damage to the urethra, fistula formation, and ED.
Okay, that covers surgery. What about radiation therapy?
Radiation therapy is the other main curative option for localized prostate cancer. It can be delivered in two main ways. External beam radiation therapy, EBRT, is the most common. It uses high-energy X-ray beams targeted at the prostate from outside the body. Treatment is typically given 5 days a week for several weeks, usually 4 to 8 weeks, on an outpatient basis.
What are the side effects of EBRT?
Side effects can be acute, occurring during or shortly after treatment, like skin changes in the treatment area, fatigue, GI issues, diarrhea, rectal irritation or proctitis, and urinary issues, dysuria, frequency, urgency, cystitis. There can also be delayed side effects months or years later, including ED, chronic bowel or bladder problems, and a very small risk of secondary cancers. The other main type of radiation is brachytherapy or internal radiation. This involves surgically implanting tiny radioactive seeds directly into the prostate gland.
Seeds inside the prostate.
Exactly. These seeds deliver a high dose of radiation directly to the tumor, while minimizing the dose to surrounding healthy tissues like the bladder and rectum. It's often done as a one-time outpatient procedure and is typically best suited for men with early-stage, lower-grade disease.
What are the side effects of brachytherapy?
The most common side effects tend to be urinary irritative or obstructive symptoms, which can sometimes be significant initially but usually improve over time. The risk of long-term bowel problems or severe ED might be slightly lower than with EBRT for some patients, but comparisons are complex.
Okay, surgery and radiation for localized disease. What if the cancer has already spread or comes back after initial treatment? What are the drug therapies available then?
Right, for advanced, metastatic, or recurrent prostate cancer, systemic therapies become the mainstay. The cornerstone of treatment here is androgen deprivation therapy, or ADT. Remember we said prostate cancer growth is often driven by androgens like testosterone? ADT works by dramatically lowering the levels of these hormones in the body, essentially starving the cancer cells.
How is ADT achieved?
It can be done medically using drugs. LHRH agonists like leuprolide or goserelin work by initially overstimulating and then shutting down the pituitary gland's production of LH, which signals the testes to make testosterone. LHRH antagonists like daguerreolex work more directly by blocking LH receptors. There are also anti-androgen drugs like bicalutamide or enzalutamide that block testosterone from binding to receptors on the cancer cells, and newer drugs like abiraterone that block androgen synthesis itself.
Does ADT work long-term?
That's a crucial point. While ADT is often very effective initially, almost all prostate cancers eventually become resistant to it over time, usually within a few years. We call this castration-resistant or hormone-refractory prostate cancer. A rising PSA level while on ADT is usually the first sign of this resistance. Also, ADT itself has significant side effects due to the low testosterone levels. These can include hot flashes, loss of libido, ED, fatigue, loss of muscle mass, weight gain, mood changes, anemia, and importantly, an increased risk of osteoporosis and fractures, as well as potential cardiovascular side effects. Careful monitoring and management of these side effects are essential nursing roles.
So ADT isn't a cure for advanced disease. What else is used?
Once the cancer becomes castration-resistant, other therapies are needed. Chemotherapy, typically using drugs like docetaxel or cabazitaxel, may be used, mainly to help control symptoms and potentially prolong survival in late-stage disease. It's primarily palliative. There are also targeted therapies now, like PRP inhibitors for men with certain gene mutations, and immunotherapy agents like sipuleucel-T, a cancer vaccine, or pembrolizumab in specific situations. For patients with painful bone metastases, treatments like external radiation to painful spots, or bone-targeting drugs like zoledronic acid or denosumab, or even a radiopharmaceutical called radium-223, which acts like calcium and delivers radiation directly to bone mets, can be helpful. And one other option for achieving androgen deprivation is surgical, a bilateral orchiectomy, which is the surgical removal of both tests. This achieves rapid and permanent testosterone suppression and is sometimes considered the gold standard for ADT, especially for rapid relief of severe bone pain. However, it's irreversible and can have significant psychological impacts on body image and self-esteem, along with the physical side effects of low testosterone.
That's a lot of complex treatment options. Thinking about the bigger picture for nursing, what are the absolute key points for managing prostate cancer, particularly regarding health promotion and those important cultural considerations?
Our nursing role in prostate cancer is truly comprehensive, spanning the entire continuum of care. In nursing assessment, subjectively, we're gathering history about risk factors, family history, current symptoms like LUTS or pain, fatigue levels, diet, and importantly, assessing anxiety and concerns about body image or sexual function. Objectively, we might note findings like an enlarged, hard, fixed prostate on DRE in later stages, or maybe pelvic lymphadenopathy. For health promotion, honestly, one of our most vital roles is encouraging men, especially those in high-risk groups like Black men or those with a strong family history, to have informed discussions with their healthcare providers about prostate cancer screening, PSA, and DRE starting at the recommended age, often 45 or even 40 for the highest risk groups. Just facilitating that conversation is huge.
So empowering men to engage in shared decision-making about screening.
Exactly. In acute care, for patients undergoing treatments like radical prostatectomy, our postoperative care is similar in many ways to what we discussed for TURP managing pain, catheters, preventing complications like DVT or infection, but there's also a huge psychosocial component. We need to provide sensitive, caring support to the patient and their family as they cope with the cancer diagnosis and treatment side effects. Encouraging participation in prostate cancer support groups can be very beneficial.
What about care after they leave the hospital?
For ambulatory care and discharge teaching, we're reinforcing things like catheter care if needed, emphasizing the consistent practice of Kegel exercises for urinary incontinence, often needing practice for many months. We provide information on managing incontinence products discreetly. For men with advanced disease, our focus shifts more towards palliative care principles, expert pain management using both pharmacologic and non-pharmacologic methods, managing treatment side effects, and helping patients and families cope with complications like bladder obstruction, bone pain, potential spinal cord compression, which is an emergency, and leg edema. It's about maximizing quality of life.
You mentioned cultural competence earlier. How does that play out specifically with prostate cancer?
It's absolutely non-negotiable. Nurses must be acutely aware of how ethnic and cultural factors influence prostate cancer risk, access to care, and treatment decisions. We know Black men have higher incidence and mortality rates. This is partly biological, but also significantly impacted by socioeconomic factors, potential mistrust of the healthcare system, lack of awareness, and barriers like financial access or transportation for screening and treatment. So our communication strategies must be tailored. We need to ensure health information about risks and screening is accessible and understandable to all men, regardless of their background. We need to build trust and address potential barriers proactively to promote equitable care and outcomes.
That's incredibly important. We've covered BPH and prostate cancer in significant depth. Now, let's broaden our view a bit to touch on a few other important male reproductive challenges, maybe starting with prostatitis.
Okay, prostatitis. This is a broad term that actually describes several different inflammatory and sometimes non-inflammatory conditions affecting the prostate gland. It's quite common, affecting maybe up to 10% of men at some point in their lives. There are different categories. You can have acute bacterial prostatitis and chronic bacterial prostatitis. These are often caused by bacteria, most commonly E. coli, but also others like Klebsiella or Pseudomonas, or sometimes STIs like chlamydia or gonorrhea, ascending up the urethra. Chronic bacterial prostatitis is actually the most common reason for recurrent UTIs in adult men.
So bacterial infections, what else?
Then there's chronic prostatitis chronic pelvic pain syndrome. This is often non-bacterial, and honestly, the exact cause is often unknown. It might be linked to previous viral illnesses or STIs, but it's often a diagnosis of exclusion. And finally, there's asymptomatic inflammatory prostatitis, which is usually found incidentally when looking for other things.
What are the symptoms like for the bacterial types?
Acute bacterial prostatitis usually presents quite dramatically fever, chills, back pain, perineal pain, along with acute urinary symptoms like burning, dysuria, frequency, urgency, and cloudy urine. The prostate gets very swollen, which can even lead to acute urinary retention. On DRE, the prostate is extremely swollen, exquisitely tender, and feels kind of boggy. Chronic bacterial prostatitis has similar symptoms, but they're generally milder and may come and go, things like irritative voiding symptoms, maybe a dull backache or perineal pelvic pain, sometimes pain with ejaculation. The DRE findings might be less dramatic, maybe just enlarged or boggy or even normal.
Can prostatitis lead to other problems?
Yes, complications can include spread of infection to the epididymitis, or bladder cystitis. It can certainly affect sexual function, causing things like post-ejaculation pain, libido problems, or even ED. A prostatic abscess is rare but possible.
How is it diagnosed and treated?
Diagnosis relies heavily on symptoms and urinalytrin culture, which will show white blood cells and bacteria in bacterial cases. Blood cultures might be needed if there's fever. PSA levels might be elevated due to inflammation, but it's not a reliable diagnostic marker here. One important point: if acute bacterial prostatitis is suspected, prostatic massage to obtain secretions for culture is generally contraindicated because it's extremely painful and risks spreading the infection systemically. Treatment primarily involves antibiotics. For bacterial prostatitis, treatment needs to be long, often 4 weeks for acute cases, and sometimes 8-12 weeks or even longer for chronic cases. Pain management is key. NSAIDs like ibuprofen, warm sitz baths can be very soothing. Sometimes alpha blockers like tamsulosin are used off-label to help relax prostate muscle tissue and reduce pain.
What if they go into retention?
If acute urinary retention occurs, a urethral catheter is usually avoided because passing it through the inflamed urethra is difficult and contraindicated. A suprapubic catheter inserted directly into the bladder through the abdominal wall might be necessary temporarily. And encouraging plenty of fluids is important, especially with fever.
Okay, that covers prostatitis. Let's also quickly touch on issues affecting the penis itself, particularly anything that constitutes an emergency.
Right. Problems of the penis, excluding STIs, are relatively rare, but some are critical. One condition that is absolutely a urologic emergency is paraphimosis. This occurs in uncircumcised males when the foreskin is retracted, maybe for cleaning or catheterization, and then cannot be pulled back forward over the glands. It acts like a tight band, constricting blood flow, and can lead to necrosis of the glands if not treated urgently.
Paraphimosis emergency. How is it treated?
Treatment involves trying to manually reduce it, pushing the glands back while pulling the prepiece forward. Ice or compression might help reduce swelling first. If manual reduction fails, a surgical procedure like a dorsal slit or circumcision is needed immediately.
Okay, paraphimosis. Any other emergencies?
Yes, another definite urologic emergency is priapism. This is defined as a painful erection lasting longer than 4 hours, unrelated to sexual stimulation. It can be caused by certain conditions like sickle cell disease, diabetes, spinal cord injuries, or drugs like cocaine or some ED treatments. The prolonged erection prevents oxygenated blood from flowing into the penis, leading to ischemia and tissue damage. Without immediate medical treatment, there's a very high risk of permanent erectile dysfunction. Treatment depends on the cause, but might involve aspirating blood from the penis, injecting medications to relax smooth muscle, or sometimes surgery.
Paraphimosis and priapism, both emergencies.
Got it.
And what about issues specific to the scrotum and tests? What are some key conditions nursing students need to be particularly aware of there?
Absolutely. The scrotum and tests are vital areas. And patient education on testicular self-examination, TSE, is so important here. One condition that is a massive surgical emergency is testicular torsion. You cannot miss this.
Testicular torsion, what happens?
It's a twisting of the spermatic cord, which contains the blood vessels supplying the testis and epididymis. This cuts off the blood supply. It most often occurs in males younger than 20. Patients present with severe, sudden onset scrotal pain, often accompanied by tenderness, swelling, nausea, and vomiting. The pain typically does not subside with rest or scrotal elevation. A key diagnostic sign that you might assess for is the absence of the cremasteric reflex on the affected side. Stroking the inner thigh normally causes the testis to elevate. This reflex is lost in torsion.
Absent cremasteric reflex. And time is critical.
Extremely critical. Diagnosis is usually confirmed with a Doppler ultrasound showing decreased or absent blood flow. If the blood supply isn't restored surgically within about 4 to 6 hours, the testes will likely become ischemic and necrotic, requiring removal. So suspected testicular torsion requires immediate surgical exploration and detorsion.
Wow, 4 to 6 hours, that's urgent. What are some other less emergent scrotal testicular issues?
Okay, less emergent, but still important. Epididymitis is an acute, painful inflammation of the epididymis, that comma-shaped structure on the back of the testis. It's often unilateral. Causes vary by age in younger men, 35. It's often due to STIs like gonorrhea or chlamydia. In older men, 35, it's more likely E. coli or related to urinary tract issues like BPH. Trauma can also cause it. Treatment involves antibiotics, treating partners too if STI related, scrotal elevation, ice packs, and analgesics. Orchitis is inflammation of the testes itself. It's also painful, tender, and swollen. It often occurs secondary to infections elsewhere, like mumps, pneumonia, TB, or syphilis. Mumps orchitis occurring after puberty is a significant cause of infertility, but thankfully it's largely preventable with the MMR vaccine. Treatment is similar to epididymitis, supportive care, pain relief, antibiotics if bacterial.
Mumps vaccination prevents infertility risk. Good point. What about lumps or swelling that aren't painful?
Right, you can have benign fluid collections. A hydrocele is a non-tender, fluid-filled mass around the testes, usually due to interference with lymphatic drainage. It typically transilluminates, meaning a light shown through the scrotum will glow through the fluid. Usually, no treatment is needed unless it becomes very large and uncomfortable. Surgical repair is generally avoided in men desiring future fertility due to a risk of impairing it. A spermatocele is similar. It's a firm sperm-containing cyst, usually of the epididymis. It also transilluminates and often requires no treatment unless symptomatic. Again, surgical repair is often deferred if fertility is a concern. Then there's varicocele. This is a dilation of the veins that drain the testes, like varicose veins in the scrotum. It often feels like a bag of worms on palpation, usually on the left side. Varicoceles are actually associated with about 40–50% of male infertility cases, possibly due to increased scrotal temperature impairing sperm production. If infertility is an issue, surgical repair, ligating the spermatic vein or injecting a sclerosing agent might be considered.
That's a very clear warning about testicular torsion and good overview of other conditions. Let's talk about the most serious testicular issue, cancer, especially given its demographic.
Yes, testicular cancer. While relatively rare overall, less than 1% of all male cancers, it's critically important because it's the most common solid tumor cancer in young men, typically between the ages of 15 and 34.
15 to 34, that's young. What increases the risk?
The biggest risk factors include a history of cryptorchidism, undescended tests even if surgically corrected, a family history of testicular cancer, HIV infection, and having had cancer in the other testes previously. Most testicular cancers arise from embryonic germ cells. The main types are seminomas, which are the most common and tend to be less aggressive, and non-seminomas, which are rarer but often grow and spread more quickly.
How does it usually present? What should young men look out for?
This is key for patient education, especially promoting testicular self-exam, TSE. The most common sign is a painless, firm lump or swelling in the scrotum. It might feel like a nodule or just a general enlargement of the testes. Some men might report a dull ache or a heavy sensation in the lower abdomen, perineum, or scrotum. Acute pain is actually rare as the first symptom. If the cancer is spread, they might have symptoms like lower back pain, chest pain, cough, or shortness of breath.
Painless lump is the key sign. How is it diagnosed and treated?
Diagnosis starts with palpation of the scrotal contents. A cancerous mass typically feels firm and does not transilluminate. An ultrasound of the scrotum is usually the next step if cancer is suspected. Blood tests for serum tumor markers, specifically alpha-fetoprotein, AFP, lactate dehydrogenase, LDH, and human chorionic gonadotropin, HCG, are crucial for diagnosis, staging, and monitoring treatment response. Other tests like chest X-ray and CT scans of the abdomen pelvis are done for staging. The good news is testicular cancer is one of the most curable solid cancers, especially if caught early, with cure rates often exceeding 95%.
That's very encouraging. What's the typical treatment?
Treatment almost always begins with surgery, a radical inguinal orchiectomy. This involves removing the entire affected testis, the spermatic cord, and sometimes regional lymph nodes through an incision in the groin, not the scrotum. Depending on the type, seminoma versus non-seminoma, and stage of the cancer, surgery may be followed by surveillance, radiation therapy, especially effective for seminomas, or chemotherapy, often combination chemo for non-seminomas or metastatic disease.
What are the critical nursing considerations for these young men?
Beyond the usual post-op care, there are major psychosocial and long-term issues. Losing a testicle, especially for young men, can significantly impact body image, feelings of masculinity, and self-worth. Providing sensitive, empathetic support and accurate information is vital. Also, radiation and chemotherapy can have significant long-term side effects, including potential lung or kidney damage, nerve damage, hearing loss, and an increased risk of secondary cancers later in life. And perhaps most critically, because treatment often causes infertility, it is absolutely essential to discuss sperm cryopreservation, sperm banking, before any treatment begins. This needs to be offered and recommended to preserve the possibility of future fatherhood. Ongoing surveillance after treatment is also critical to detect any relapse early.
Sperm banking before treatment, a crucial point. This brings us naturally to another sensitive but incredibly important area for male health: sexual function and fertility itself. Let's maybe start with vasectomy.
Okay, vasectomy. This is a common surgical procedure performed for male sterilization. It involves bilaterally ligating or resecting a portion of the ductus deferens, also called the vas deferens, the tubes that carry sperm from the epididymis. It's usually a quick procedure done under local anesthesia in an outpatient setting. Key information for patients is that it doesn't affect hormone production, the appearance of the ejaculate, sperm is only a tiny fraction of semen volume, or the physiological mechanisms of erection and orgasm. However, it is absolutely crucial they understand that sterilization is not immediate. They must use alternative forms of contraception until semen analysis confirms the absence of sperm, which can take several weeks or months and multiple ejaculations. There can also sometimes be psychological adjustments needed, as some men might subconsciously associate vasectomy with castration, even though it's physiologically very different.
Good points about the follow-up testing. Now let's talk about erectile dysfunction, or ED. It seems far more common than many people realize and can be incredibly distressing.
Indeed it is. ED is formally defined as the inability to attain or maintain an erection sufficient for satisfactory sexual activity. And you're right, it's very common. Estimates suggest over 10 million men in the United States are affected, and the incidence increases significantly with age. Maybe 50% of men between the ages of 40 and 70 experience some degree of ED. So yes, it's prevalent and can cause significant personal and relationship distress.
What causes ED? Is it mostly physical or psychological?
It can stem from a wide range of factors, often a combination. Physiological causes are very common, especially as men age. These include conditions like diabetes, mellitus, vascular diseases, atherosclerosis, hypertension, peripheral vascular disease, basically anything affecting blood flow. Neurological disorders, trauma like spinal cord injury or pelvic surgery like radical prostatectomy, chronic illnesses like kidney failure or liver disease, low testosterone, hypogonadism, and side effects from numerous medications.
What kind of medication?
Oh, many common ones. Alcohol, antihypertensives, especially beta blockers and thiazide diuretics, major tranquilizers, antidepressants, particularly SSRIs, nicotine, opioids, the list is long. A gradual onset of ED often suggests underlying physiological factors. Psychological causes are also important, especially in younger men. Things like performance anxiety, depression, relationship difficulties, stress, or guilt can contribute. A sudden or rapid onset of symptoms might point more towards a psychological trigger. Often, though, there's an interplay between physical and psychological factors.
How does ED impact patients?
The impact can be profound. It can cause significant distress in interpersonal relationships, interfere with intimacy, and negatively affect a man's self-concept, self-esteem, and sense of masculinity. This can lead to feelings of anger, anxiety, and depression, creating a vicious cycle.
How do we diagnose and manage ED? What's the process?
Diagnosis always starts with a thorough history. Sexual history, medical history, psychosocial history. We need to understand the onset, duration, and nature of the problem, relationship factors, medication use, lifestyle factors. Standardized questionnaires like the International Index of Erectile Function, IEF, can help quantify the severity and different aspects of sexual function. A physical exam focuses on looking for signs of underlying disease, assessing secondary sexual characteristics, doing a DRE to check the prostate, checking blood pressure, and peripheral pulses. Laboratory tests are usually done to rule out common underlying causes, serum glucose and HbA1c for diabetes, a lipid profile for cardiovascular risk. Hormonal levels, including testosterone, prolactin, LH, and thyroid hormones, help identify any endocrine problems. Sometimes more specialized tests are needed, like nocturnal penile tumescence and rigidity testing, to see if erections occur during sleep, helping differentiate physiological from psychogenic causes, or vascular studies like Doppler ultrasound to assess blood flow in the penis.
Once we have an idea of the cause, what are the treatment approaches?
The goal is really for the patient and their partner to achieve a mutually satisfactory sexual relationship. Treatment often begins by addressing any reversible causes, maybe changing medications, managing underlying health conditions like diabetes or hypertension better, addressing lifestyle factors like smoking or excessive alcohol use. Counseling, often with a qualified sex therapist, is highly recommended, especially if psychological factors seem prominent or if the ED is causing significant relationship stress. This can involve the partner too.
What about medications for ED? Viagra is well known.
Yes, the oral phosphodiesterase type 5 (PDE5) inhibitors are the first-line medical treatment for most men. These include sildenafil, Viagra, tadalafil, Cialis, vardenafil, Levitra, and avanafil, Stendra. They work by enhancing the effect of nitric oxide, which relaxes smooth muscles in the penis, allowing increased blood flow needed for an erection. Importantly, they don't cause an erection directly. Sexual stimulation is still required for them to be effective.
Are there major side effects or warnings?
Common side effects can include headache, flushing, nasal congestion, indigestion, and sometimes muscle aches or back pain, particularly with tadalafil. The most critical warning, a major drug alert for nurses, is that PDE5 inhibitors are absolutely contraindicated for patients taking nitrates in any form, like nitroglycerin for angina. The combination can cause a sudden, severe, potentially life-threatening drop in blood pressure. We must screen carefully for nitrate use.
Nitrate contraindication vital. What if oral meds don't work or aren't suitable?
There are other options. Vacuum erection devices, VEDs, are external pumps that create suction to draw blood into the penis, creating an erection, which is then maintained by placing a constriction band at the base of the penis. There are also medications that can be administered directly into the penis. Intraurethral medication pellets, like MUSE, containing alprostadil, can be inserted into the urethra. Or intracavernosal self-injections, where the patient injects vasoactive drugs like alprostadil or combination mixtures like Trimix directly into the corpora cavernosa using a tiny needle. These methods induce erections by directly relaxing smooth muscle and increasing blood flow. For men who don't respond to or can't use other therapies, surgically placed penile implants or prostheses are an option. These involve placing inflatable or semi-rigid cylinders inside the corpora cavernosa, allowing the man to create an erection mechanically. Complications can include infection or mechanical failure, but satisfaction rates are generally high for well-selected patients.
It sounds like sexual counseling could be helpful throughout this process.
Absolutely. Sexual counseling is highly valuable at any stage, whether ED is primarily psychogenic or physiological. It helps address psychological factors, improves communication between partners, manages expectations, and helps couples adapt to different treatment options or changes in sexual function.
Okay, what about that gradual decline in male hormones that sometimes comes with aging? Is that related?
Yes, that's hypogonadism, sometimes referred to as late-onset hypogonadism, or even colloquially as male menopause, though that term is a bit misleading. It's basically a gradual decline in androgen secretion, primarily testosterone, that can start as early as age 40 for some men. Obesity is also a significant contributing factor.
What are the signs of low testosterone?
The manifestations can be quite varied and sometimes subtle. Common ones include decreased libido, sex drive, fatigue or decreased energy levels, erectile dysfunction, changes in mood like depression or irritability, and sleep disturbances. Longer-term effects can include loss of muscle mass and strength, increased body fat, decreased bone density, increasing risk for osteoporosis and fractures, and reduced body hair. Many of these symptoms are pretty general and can easily be overlooked or just attributed to getting older.
How is it diagnosed?
Diagnosis requires both the presence of signs and symptoms and laboratory confirmation of low testosterone levels. Typically, this means measuring total serum testosterone levels on at least 2 separate occasions, usually early in the morning when levels are highest. A level consistently below about 300 ngDL is generally considered low, though reference ranges can vary slightly.
If diagnosed, is testosterone replacement therapy, TRT, recommended?
Testosterone replacement therapy, TRT, may be considered if a man is diagnosed with hypogonadism, low T+ symptoms. However, it requires a very thorough discussion between the patient and their healthcare provider about the potential risks and benefits. Critically, TRT is contraindicated in patients with known or suspected prostate cancer because testosterone can stimulate its growth. It's also generally avoided in men with severe, untreated BPH for the same reason, or those with certain other conditions like severe heart failure or sleep apnea. A DRE and PSA test should always be done before starting TRT and monitored regularly during therapy.
How is TRT administered?
TRT comes in several forms. Intramuscular injections like testosterone, cypionate, or enanthate are common, usually given every 1 to 4 weeks. Transdermal patches like androderm or gels like androgel testim applied daily to the skin are also very popular. There are also buccal systems that stick to the gums, and even intranasal preparations now. Injections can sometimes cause mood swings due to the fluctuating hormone levels between doses. Transdermal products provide more stable levels but require daily application.
Any safety concerns with the transdermal ones?
Yes, a key safety alert with transdermal gels and solutions. It's crucial to emphasize meticulous hand washing after application and covering the application site with clothing. This is to prevent accidental transfer of testosterone to others, especially women of childbearing age and children who could experience adverse effects like virilization if exposed.
Good safety tip.
Yeah.
Finally, let's briefly touch on infertility, a very sensitive topic for many couples.
Yes, infertility. Clinically, infertility in a couple is defined as the inability to conceive after 1 year of frequent, unprotected intercourse, or 6 months if the woman is over 35. It is absolutely crucial to approach infertility as a couple's problem, not just an issue with one partner. Both partners must be involved in the evaluation and support process. Male factors are estimated to contribute to or be the sole cause in about 40% of infertility cases.
What causes male infertility?
The causes can be broadly categorized. Pretesticular causes are usually endocrine problems affecting the hypothalamic pituitary gonadal axis, maybe hormonal imbalances. These account for only about 3% of cases. Testicular causes are the most common, making up about 50% of cases. This includes problems directly affecting sperm production in the testes. The single most common correctable cause is a varicocele, that venous dilation we discussed. Other testicular factors include infections like mumps, orchitis, STIs, congenital anomalies like Klinefelter syndrome or Y chromosome microdeletions, effects of drugs like chemotherapy, anabolic steroids, radiation exposure, systemic illnesses, substance use, alcohol, nicotine, marijuana, and exposure to environmental toxins or heat. Post-testicular causes involve problems with sperm transport or ejaculation, maybe due to obstruction in the reproductive tract, like from prior surgery, infection, or congenital absence of the vas deferens, ejaculatory duct obstruction, or retrograde ejaculation. These account for maybe 5–7% of cases. And then, in a significant portion, maybe around 40%, the cause remains idiopathic, meaning we can't identify a specific reason despite thorough evaluation.
How is male infertility diagnosed?
Diagnosis starts with a very careful health history from the male partner, covering developmental history, past illnesses, surgeries, especially inguinal or scrotal, infections, STIs, mumps, medications, occupational exposures, lifestyle factors, hot tubs, tight underwear, substance use, and sexual practices. A physical examination focuses on genital anatomy, looking for things like varicocele, testicular size and consistency, presence of the vas deferens or signs of hypogonadism or Peyronie's disease. The cornerstone of male infertility testing is the semen analysis. This evaluates several parameters: sperm concentration count, motility, percentage of moving sperm, and morphology, percentage of normally shaped sperm. Usually at least 2 analyses are done. Hormone studies like plasma testosterone, serum LH, FSH are also often performed to assess the endocrine axis.
What's important for nurses when dealing with infertility?
Tact and sensitivity are paramount. Infertility can be an incredibly stressful and emotionally charged issue for couples. Many cultures equate fertility with masculinity, so discussing these issues requires immense sensitivity. We need to create a safe and supportive environment.
What are the treatment options?
Treatment options depend entirely on the underlying cause. They might include specific medical treatments for infections or hormonal imbalances, lifestyle modifications like avoiding scrotal heat, quitting smoking, reducing alcohol, surgical correction of anatomical problems like varicoceles or obstructions, or assisted reproductive technologies, ART, like intrauterine insemination, IUI, or in vitro fertilization, IVF, with intracytoplasmic sperm injection, ICSI. Counseling is often essential for couples navigating the emotional challenges of infertility and treatment decisions.
Wow, that was truly a comprehensive deep dive into the complex world of male reproductive health. We've navigated everything from really common conditions like BPH through life-altering challenges like prostate and testicular cancer, and also covered sensitive but critical topics like ED and infertility.
Yeah, we covered a lot of ground. Our goal today was really to arm you, our future nursing colleagues, with the essential knowledge from Lewis's medical surgical nursing, distilled into manageable and hopefully memorable nuggets. Remember, as you move forward in your studies and into practice, your role in performing skilled assessments, providing empathetic and clear patient education, and delivering holistic care for men facing these diverse challenges is absolutely paramount.
So, reflecting on everything we've discussed, what really stands out to you after this deep dive? Maybe think about how these interconnected systems and conditions truly emphasize the importance of taking a thorough patient history, right? And maintaining that compassionate approach in every single interaction, really seeing the whole person beyond just the diagnosis.
That's a great point. And I'd add, consider how powerful targeted patient education can be. When we tailor our teaching to address individual cultural backgrounds, specific concerns, and literacy levels, we can truly empower men. Empower them to seek early screening when appropriate, to understand and adhere to complex treatment plans, and to effectively manage chronic conditions. This significantly impacts not just their physical health outcomes, but also their overall quality of life, their relationships, and their sense of well-being.
Well said. Thank you so much for joining us on the deep dive. We sincerely hope this exploration has given you a clearer understanding and maybe boosted your confidence a bit in this really critical area of nursing.
And on behalf of the Last Minute Lecture team, thank you for learning with us today. Keep diving deep.